Hello, my name is John Paulides, and I'm internal medicine resident at Orlando Regional Medical Center in Orlando. It is my pleasure to present to you a rare case of drug-induced pancreatitis after prophylactic monoclonal antibody treatment against SARS-CoV-2. This is the case of a 65-year-old male with a past medical history that was significant for coronary artery disease, hypertension, hyperlipidemia, and obesity, who presented to the emergency department with 2 days of epigastric pain, nausea, vomiting, and inability to tolerate PO. Upon further history, he had been feeling unwell for the past week, and although having a negative PCR test for SARS-CoV-2, believed that an infusion of M.A.B would be an appropriate therapy. Shortly after receiving the medication, he started to note the symptoms that caused him to present to the hospital. On admission, his vitals were significant for hypertension and tachycardia. He was on room air and moving oxygen well. Labs were drawn and revealed a lipase of greater than 3,000. A CT of the abdomen and pelvis was then obtained and revealed radiologic findings suggestive of pancreatitis. Other causes of pancreatitis were ruled out, including any biliary pathology. He had no history of alcohol abuse, no recent abdominal trauma. Triglycerides were only mildly elevated, and he had no history of scorpion stings. Here are his pertinent labs for review. SARS-CoV-2 is an enveloped positive-sense single-stranded RNA virus and belongs to the family Coronaviridae. To truly understand the virus, you must be familiar with the mechanism by which it enters the host cell. The cell entry mechanism of SARS-CoV-2 has been extensively studied. It has a spike protein with two subunits, S1 and S2. S1 contains a receptor binding domain that specifically recognizes angiotensin converting enzyme 2, or ACE2, as its receptor. Moreover, to fuse membranes, the SARS-CoV-2 spike protein needs to be proteolytically activated at the S1-S2 boundary, such that S1 dissociates and S2 undergoes a dramatic structural change. One of the proteases that it uses is TMPRSS2. Both ACE2 and TMPRSS2 are expressed in nasal, bronchial, and GI epithelium, giving the virus the ability to rapidly spread and cause the severe symptoms that infected patients face. The monoclonal antibodies that are currently available have been developed to disrupt this process. So M.A.B is intended for use in patients with mild to moderate SARS-CoV-2 infection who are at risk for development of severe disease. Patients who may be at higher risk have the characteristics listed below. There are currently 3 monoclonal antibodies in use for the treatment of mild to moderate SARS-CoV-2 infection, and a 4th is coming down the pipeline. So M.A.B was derived from the memory B cells of a patient who recovered from SARS-1 in 2003. It is a recombinant human monoclonal antibody modified in the fragmented crystallizable region that binds to a conserved epitope on the spike protein receptor binding domain of SARS-CoV-2. This effectively disrupts the virus from entering host cells. It received emergency use authorization from the U.S. FDA in 2021 for the treatment of patients with mild to moderate SARS-CoV-2 who are at higher risk for progression to severe disease. In the COMET ICE trial, compared to placebo, M.A.B was associated with 6% absolute reduction and 85% relative risk reduction in all-cause hospitalizations or deaths. The only reported side effects were infusion-related reactions, hypersensitivity reaction, rash, and diarrhea. Acute pancreatitis was not reported as a side effect in the clinical trials. However, now that the sample sizes are becoming larger, more data will become available. Correlation does not imply causation, but in patients with acute pancreatitis, the recent use of M.A.B should be considered as an inciting event. I felt that this was an important case to present because as monoclonal antibodies become more widely used for the treatment of SARS-CoV-2, it's important to look out for the early signs and symptoms of pancreatitis. especially given its propensity to cause severe morbidity and mortality when left untreated. Thank you very much.